It's a pleasure for us, Professor Witjes, to receive you here today for your presentation. Thank you very much. You could speak as soon as you can, as possible as you can. Thank you.
Okay, thank you very much. Thank you for the invitation. I will try to share my screen if I'm able to do that. You see my screen?
Yes.
Okay,
yes,
great.
Okay.
Just take out all the pictures here. So I heard that, you know, the audience for today is partly urologists, partly researchers. So I'll tell a little bit of both. So the urology part will be not interesting for the urologists, but maybe for the researchers, and the other way around. I do have some conflicts of interest, which are not relevant for this lecture, although I did studies without any financial compensation with most of the urinary tests that are currently, the markers that are currently being applied in clinical practice. So just as a starter, how do we diagnose bladder cancer, non-muscle invasive bladder cancer as urologists? Of course, patients will have hematuria. Then we do a cystoscopy. We do cytology as sort of a marker, and we might try imaging. So cystoscopy, as you can already see here, it's not a very convenient investigation. The males probably think that they will never hope to have this, but it's also not very good. We know from several studies, so the top study we did within the European Organization for Research and Treatment of Cancer, published that in 2002, and you see there that the 3-month recurrence rate is around 3 but to 45%. And believe me, these tumors do recur, but not that quick. So probably most of these 45.8% are missed lesions during the initial investigation. And I'm sure that we do better in 2022, 2023, but still cystoscopy is not ideal. If you look at the studies that we did with blue light in the beginning of the century, you see that, for example, for CIS, we miss around 62% of the lesions, but also 30% of patients that have carcinoma in situ. And believe me, carcinoma in situ is an aggressive tumor, so you don't want to miss that with white light. Blue light certainly does better. One of the advices in the guidelines is to do a re-TOR, so re-resection of the tumor when you did an initial resection, and in over 50% of these resections, the second resection is positive, meaning that the initial resection was not complete or that you missed the tumor. So for sure, there is some improvement possible. How can we do that? Well, you can do a second TOR. I would say, why not be adequate to the first time? You can train your residents to do a TOR. You can use air cystoscopy. I'll show you a picture of that. And you can use enhanced imaging with blue light. That's the one that is used the most. You see, for example, air cystoscopy. I do that a lot by our patients. This is a picture, a tumor probably with some bleeding. If you take out the fluid, the urine, and only put in air, you can see very nicely where the tumor is. And here the same, it's very difficult to see here. You see a very nice tumor. So using that in air sometimes gives you a lot more information than only using water. The second thing that we use is fluorescence, so photodynamic diagnosis. You see an example of a bladder that we see as urologists almost every day. And then maybe there is some tumor here or there, or maybe there. It's not very clear. If you use blue light, you see that everything that is pink, that's tumor. Everything that is blue or purple is no tumor. So this really helps you in finding tumor. And this is a patient that had CIS. And you know, I've done a lot of cystoscopies. I really wouldn't have thought that there was something here. But here you very clearly see that there is a spot that is absolutely abnormal. So again, with blue light, you can enhance your diagnosis. What about cytology? You probably know that the sensitivity of cytology in this review is reasonable. You see here it's 44%, but I think in normal practice it's much lower. Specificity though is good. You know, if a cytologist says that it is tumor, very probably this is tumor. But it's, for example, dependent on infection, dependent on handling, dependent on cytologist. So it's not a very objective measurement. And then imaging, this is something new, and certainly you should be aware of that. You can do ultrasound of the bladder, but MRI of the bladder is currently coming into the guideline, and it will have a very prominent role, I guess, in the coming few years, and especially to investigate the bladder to see the difference between a non-invasive tumor and an invasive tumor. Invasive tumor means cystectomy. Non-invasive tumor means intravesical therapy. So it's a big difference in therapy. And also, of course, you can image nodes or metastases. And this is indeed how you see the virus system. So that's the visual imaging, reporting, and data system of the bladder. Sorry, visual vesicle. You see here there are criteria to suggest that it is a non-invasive tumor or to suggest that it is an invasive tumor. And you very nicely see a non-invasive tumor. So the muscle layer is absolutely not involved. And you see, of course, the tumor that's growing outside the bladder, T3 tumor. So markers, is that a solution? I've been studying markers for now, I think, around 20 or 25 years, and especially the older ones never brought what we or the patients would like to have. You see the fish, that's an aneuploidy of 4 chromosomes, and you see it looks very nice. It's also a fluorescent in situ hybridization, but it's a very expensive technique. And see that sensitivity, okay, specificity goes a bit down. So in all, it's not that much better than cytology. Same goes for the NMP22 test. There is also a rapid test. This, of course, is a small advantage. This takes only 45 minutes, like the COVID test that now everybody knows. But still, you see sensitivity, not very good. Specificity, also not really optimal. So also, the NMP22 test has never brought what we would like it to do. That's why not only in this presentation, but also in the EU guideline, actually, there is a quite clear conclusion that used to be, it's a little bit different now, I'll tell you that in a minute. Several urinary markers have higher but still insufficient sensitivity compared to cytology. They have been studied extensively to decrease need for cystoscopy, but no marker was available at present that can sufficiently warrant this. So cytology or markers cannot safely replace cystoscopy. However, I think there has a changed end in the markers and in the way that we use the markers. So for me, a very logical way of doing that is in follow-up. Screening for bladder cancer is not done in the Netherlands. I know that the German company, the BASF company, does that. You see that the A stands for aniline, and aniline is something that causes bladder cancer. And they have used for some time the NMP22 dipstick test. The German Euroscreen study, which was done by BASF and by Bayer, and indeed indicates that urine-based molecular markers could be a suitable solution to urine cytology in detection of microhematuria. But those are then people working in these companies and being at higher risk for bladder cancer. What about hematuria workup? I assume that if a patient has hematuria, that every urologist will probably do a cystoscopy. What about follow-up? I think that's a good indication. You know your patient, you know that he had, for example, a TA tumor or T1 tumor, so you already have some information before you do the test. And the second thing that is new, that we now have other markers, epigenetic urinary markers. They recently have been investigated, they're very promising. They were published. The goal is indeed to reduce the follow-up ureterocystoscopy frequency. And of course, the advantage compared to cystoscopy, it's non-invasive and it has no side effects. You know what epigenetics are? These are factors that switch on or off genes and affect how cells read genes without altering the underlying DNA sequence. Potential consequences is cancer development, cancer progression, and thus impact on therapy. You have 3 categories. You have abnormal aberrant DNA methylation, hypermethylation, or hypomethylation. You have histone modification, and you have non-coding RNAs. Why are they so important in cancer, or specifically in bladder cancer? Well, with the current high throughput sequences, the research is much better and much easier and much quicker than it used to be. The body of literature is growing exponentially. You see more and more studies on epigenetics and cancer. Epigenetic cancer changes are frequent in cancers, also in urological cancers, but also in bladder cancer, muscle invasive and non-muscle invasive bladder cancer, both in tissue, but also in urine. And that might, of course, be useful in diagnosis, prognosis, and maybe a potential target for therapy, since some of these changes are reversible. I will mention a few. So one of the tests that I've been working with a lot is the bladder EpiCheck test. It's a real-time PCR. You only need 10 mL of urine, and it uses 15 proprietary DNA methylation markers, not the 15 best ones, but the 15 complementary ones. You get a score between 0 and 100, and above 60, it is positive. These are some of the studies that we've done. We also studied that. You see that the negative predictive value, because that is what I want. I would otherwise do a cystoscopy anyway. So I would like to have a good argument to not do a cystoscopy. Just for your information, in my outpatients, we do hundreds of cystoscopies. Around 10 to 15% are positive. So that means that 85 to 90% of cystoscopies are done for nothing. And again, it's an invasive test. You see the negative predictive value for all grades is very high, and for non-low grade, so let's say the dangerous ones, it's almost 100%. So this really looks promising. We checked whether it is cost effective, and we use that now, and I'll show you in the end of my lecture why we start using that. We now do that alternating with cystoscopy. So half of the follow-up appointments, according to the EAO guideline, are done with the bladder AP check to rule out cystoscopy. And of course, maybe you delay the recurrence detection, and that might be the disadvantage. You'll see here that the delay in detection of recurrent disease would be 3.9, 1.7, and 1.3 months in low, intermediate, and high-risk patients. So basically, you don't miss them a lot. And you see that the cost reduction is not huge, but still, it's 8, 4, and 9% in low, intermediate, and high-risk patients, which for the Netherlands would translate into 1.6 billion euros per year. So we concluded that this test can be used to reduce the cost on the muscle-invasive bladder cancer follow-up with only a very small delay in diagnosis of recurrent disease. There is the expert bladder cancer monitor. Again, 5 messenger microRNAs are targeted. The assay is performed in a self-containing cartridge, which is an advantage because this equipment is almost available in every hospital for diagnosis of bacteria, infections, but also in this case for a urinary marker, and it's a quick turnaround time of only 90 minutes. And you see here again that the negative predictive value is 93% for all tumors and even 97% for the high-risk tumors. So again, a very high negative predictive value. Then you have the Euromonitor test. It's also a very convenient test. You probably know that you only need a little bit of urine. You press it through 3 of these sort of cylinders where cells are harvested. We did some preclinical work with that, and initially it was a third promoter, and the FGFR3 hotspot mutations were used. And you see in the phase 1 study, we used around 300 plus urinary samples and tissues, and the clinical validation was also done in a little bit less samples, and the result was a high sensitivity and a high specificity in detecting recurrence of bladder cancer in patients under surveillance of non-muscle invasive bladder cancer. And again, that under surveillance, I guess, is the ideal indication or way to use these tests. We did the clinical validation with the Euromonitor. Then the third aspect was added, the CRAS, for evaluation of disease recurrence. We used 105 patients to follow up for non-muscle invasive bladder cancer. They all, of course, underwent the standard of care, cystoscopy and cytology. You see that the Euromonitor has a very high specificity and a very high negative p-value of respectively 85 and 95%. And cytology did much worse. So especially the negative predictive value of cytology is something that you can't use in clinical practice. So we concluded that with the high negative predictive value of 95% of the Euromonitor test, it is a promising property for the follow-up of patients with non-muscle invasive bladder cancer. This is a recent report, and again, you see here that was 202 patients studied this year and reported this year with the Euromonitor, high sensitivity and a very high specificity of 96.2%. And again, this is a test that you can really use in clinical practice. There are some other tests, the CX bladder test. It's not available in Europe yet. They're probably going to do a study with that. But again, you see that the negative predictive value is good. It's high, it's 97%. And the 8X bladder cancer test, again, that one is available in Europe. It's tested by Morgan-Rupert in France. Negative predictive value for all tumors, 93%, 99% for higher risk patients for the non-PTA low-grade tumors. So again, all these tests have similar but very high negative predictive values. This is a nice study, a nice review published last year about all the tests that you can do, the protein test, microRNA or DNA methylation. You see the number of cystoscopies avoided with every test is high. It's for the Euromonitor 700 plus patients, if you look at 1,000 patients with any grade muscle-invasive, non-muscle invasive bladder cancer, recurrences missed is low. 10 out of 1,000 patients with a urine monitor test. Unnecessary cystoscopies, because of course some tests are false positive. They are also not that big, because you have to realize otherwise these patients would have had a cystoscopy anyway. You see for the urine monitor is only 124, and recurrences that are found is 170. So in all these tests do quite well. Urine monitor certainly is not the worst one, so it does quite well in clinical practice. So if you conclude on these tests, the older ones are not widely used because of costs, practical aspects, or insufficient sensitivity or specificity. In follow-up, a test with a high negative predictive value, at least for high-risk recurrences, may result in less cystoscopies. A follow-up test with a high specificity will result in fewer unnecessary cystoscopies. And alternating cystoscopy and cytology with one of these new tests could reduce the current diagnostic burden. And if you see the 2022 and also in the 2023 EU guideline, now there is mentioning of follow-up markers in the guideline. And they only mention these few, which of course one is not even available in Europe. And your urine monitor was in 2022 not included yet. But you see they have such high sensitivities and negative predictive values in the studies for high-grade disease that they may approach the sensitivity of cystoscopy. And again, to be honest, and I'm a urologist, I shouldn't say that, but I have the impression sometimes that these tests are more sensitive than my cystoscopy and my eye. So these 4 tests might be used to replace and or postpone a cystoscopy, as they may identify the rare high-grade recurrences occurring in bladder cancer patients. Not mentioned in the AUA update of 2020 because this update is too old, but the European update did mention these tests. How did we implement that in our clinical practice? So the number of follow-up cystos is high. It's a lot of workload. Like I told you, around 10 to 15% has a recurrence. So if there is a low-grade recurrence based on histo and on history and cysto image, I even do active surveillance, which means that usually, unfortunately, these cystos stay without consequences. So we do a lot of cystoscopies in vain. Since the APCheck testing is available and reliable, we currently alternate an APCheck test with a cystoscopy. And if the test is positive, we can still do a cysto. And to prevent unnecessary traveling, which is patient comfort, costs, and the reason why we started that was at the beginning of the pandemic, when we were not allowed to see patients. We just finished the APCheck study, and we said, well, it's convenient. Let's try to do that at home. So patients void at home, send the urinary sample to the laboratory. I get the result, and I call them at home. So the initial, implementation was forced or made possible or made necessary due to the limitations we had in our hospital due to the COVID infection. Some practical issues, of course. The advantages is less workload. Patients are happy. The test might very well be better than our eye. And macroeconomically, the strategy is cheaper. Patients don't have to travel. They don't have to park. They don't have to take off work. The disadvantage is also clear that the hospital or the urologist might lose some money because they don't have the income which they can get by a cystoscopy, and they have to pay for the test. So that depends on some creativity, which we have done in my hospital. But on the other hand, you will have time for other work, which means another source of income. And then the patients, what do they think? Well, this is a quite recent study from the United Kingdom. And patients said, well, nearly all patients, 85% of patients, demanded a test sensitivity of at least 99%. And I have to be honest, none of those tests has that. They actually demand the biomarkers to be as sensitive as cystoscopy. Well, cystoscopy obviously is not 99% sensitive, and I think it's not the sensitivity, but the negative predictive value that could be useful for patients. So I think also with regard to patient preference and urological preference, we will need to do some re-education. So concluding, the diagnosis of non-muscle invasive bladder cancer, beware of the limitations of cysto and of cytology. Imaging can be helpful, especially to see the difference between an invasive and a non-invasive tumor. Treatment, of course, is according to guideline. A follow-up, as we do that currently, just look at the levels of evidence, has a very low level of evidence. We do that already for 20, 30, 40 years, just as we did that some time ago, and we still do it now. Markers to replace cystos or part with cystos is an unmet need, both with regard to patient burden and costs. The bar for patients and urologists is high, so we have to do some re-education that even if we miss a tumor for a short period of time, it's not harmful. For follow-up, several markers have a very high negative predictive value, let's say close to 100% for high-rate recurrences. Mind specificity, that also should be high to avoid unnecessary cystos. And the practical implementation is running worldwide, Europe-wide. I see that now more and more coming, and it looks very convenient for all parties. That's what I wanted to tell you about markers in bladder cancer, and if there are questions, I'm happy to answer them.
Thank you for Professor Witjes. Thank you for the nice presentation. You reinforced the value for tumor biomarkers detected in biological samples like urine, and considering patients' preference and at all. Moreover, you showed us some examples of urinary biomarkers for monitoring patients with bladder cancer and done comparisons. There are some concepts that we should consider when we talk about tumor biomarkers, and you showed how a high sensibility and specificity is important.
So, you know, again, I'm really emphasizing the use in follow-up. Some of these tests are now used for screening to see whether they also are good for screening. Unfortunately, we still don't have good tests for prognosis. So there are no tests currently, and that's for the researchers to work on to predict, really therapy, maybe FGFR3, or predict a worse prognosis. That's really an unmet need still. For example, a T1 patient, some progress and will die of the disease. Some will not progress. I would be very happy if there would be a test that predicts those patients that do worse and those patients that do well. Unfortunately, even after 30 years of study and of research, we don't have those tests yet, but I hope they will come.
Yes, sure. We are open for questions now. Fernando,
I just would like to say thank you very much, Professor. As always, the presentation was fantastic. I just would like to say to the audience, if there is any need for translation or you feel comfortable with English, please do put it or on the chat or say it in Portuguese, and I will be more than happy to translate it into English or Dutch, which Professor Witjes do not agree with my Dutch, but okay, I can try in Dutch or in English for sure to translate your questions that you might have.
Pessoal, quem tiver perguntas aí, quiser falar em português pelo chat, a gente consegue traduzir para o professor Witjes. Quem tiver considerações também a fazer sobre a fala da doutora Sheila, por favor, fique à vontade. Quem quiser abrir a câmera também.
Yeah, sorry, my Portuguese is still crap, so...
Well, I would like to inform all of you that Professor Witjes, although he's from Holland, he is in Portugal currently, so... He's in Portugal now. Well, yeah. I don't know exactly where he is far from me, but he's somewhere in Portugal.
No, I'm in the Algarve, so in Albufeira, really enjoying the weather and the atmosphere here. So, okay, if there are no questions, I hope that you have a good further meeting. And if there are any questions, just mail me or mail Fernando.
Sure. I put a message here for everyone who's participating. And like, if you think tomorrow, like, oh, I forgot this or I didn't understood this or that, send me an email. You guys all have my email. I put it there in the beginning of the meeting, and I'll be more than happy to answer it. If I can't, obviously, I can always ask Professor Witjes, and we will answer all your questions or doubts that might arise.
Okay.
Thank you so much, Professor.
Bye-bye.
Enjoy the Algarve.